Now, telemedicine is basically converting manual records. The record could be a physical examination, the record could be a history taking, the record could be a CT image, laboratory investigations, and what have you, basically converting them to a digital component. Now, obviously, depending on what is to be converted, the bandwidth required can be from very low to extremely high bandwidth. Now, I just want to spend 2 minutes on summarizing what exactly is telemedicine. Telemedicine involves, obviously, in my generation, we used to call them doctors. Today, we call them healthcare providers. We used to call them patients. Today, we call them beneficiaries. Today, you have hardware, software, connectivity, acquisition of data, storage of data, retrieval of data, display of this data. Exactly 20 years and 1 day later, the Board of Governors, in supervision of the Medical Council of India, notified an amendment to the Indian Medical Council Act. Some of us from the Telemedicine Society of India have been working very hard for several years to achieve this. Now, there have been concerns. Several people have asked me, they are saying, look, this is all right, but this is for the COVID-19. Once it is denotified, the virus goes away, then what happens? I would like to reassure every single person here that this act is not, I repeat, not notified either under the Epidemic Diseases Act of 1897 or even the Disaster Management Act of 2005. It is an amendment to the existing Medical Council of India Act. Ladies and gentlemen, it is here to stay. Telehealth or remote healthcare is going to be the new normal. Again, another advantage with newcomers in telemedicine have got is both these acts unambiguously state that no suit or any legal proceeding can lie against any person for anything done or in good faith intended to be done under this act, which means that if you have genuinely made a mistake, it is only a procedural lapse while trying to diagnose a COVID-19 or something like that. Even if something wrong as goes, you are exempted, you are indemnified from any action being taken against you, because today the Epidemic Diseases Act and the Disaster Management Act have been notified. Now, 3.3.1 is a specific notification of the paragraph. I've already told you the Indian Medical Council Professional Code of Conduct, which gives statutory support and so on. Now, let's go to the next slide. You see here, I have highlighted it in yellow, shall be permissible. Teleconsultation shall be permissible in accordance with the telemedicine practice guidelines. In other words, this is not a guideline in the simplistic sense of the word. It is law, it has been notified, it is an amendment, and it will be published as an e-gazette very soon, but it already has the enforcement of law. Now, telemedicine is to enhance health services and access to everyone in India. It doesn't matter whether you're registered under the Tamil Nadu Medical Council or the Karnataka Medical Council, so long as the doctor and the patient are physically somewhere within the Indian province, you are eligible to give teleconsultation. The law, the guidelines are still not clear whether a doctor physically based in India can give a consultation to a patient outside India, or whether we can take a teleconsultation from a doctor outside India. The law is still not clear. We have noted down all this, and I'm sure there will be amendments and modifications, etc., as time passes. Now, something else, most traditionally people have been criticizing the government for decades. Now, just look at this. On 24th of March, a document was sent by the Board of Governors, MCI, to the Ministry of Health. And within 12 hours, the ministry has notified it. Within 12 hours, a paper has been approved and this has become law. So this very clearly indicates how serious the authorities are in the deployment of telehealth. The Government of India notifications are extremely doctor-friendly. Of course, a lot of tweaking has to be made, but I'm sure this is going to happen during the next few months. Now, let's go into the details, particularly how it's going to affect each one of us. Now, patient consent for teleconsultation is implied if the patient initiates the teleconsultation. When a patient comes to me for a face-to-face consultation, I do not. Now, of course, some hospitals may, but as an individual clinics, a doctor normally does not take a consultation for a consent form for a consultation. The same thing applies in any form of teleconsultation, provided the patient has initiated the request for a teleconsult. An explicit consent, patient consent, is needed only if a health worker. Now, we are looking at a situation, particularly in a pandemic situation, where an ASHA, a health worker, a nurse, a paramedic, anybody could initiate a teleconsultation. I think this is fantastic. Many countries do not even talk about this, but Indian rules now say that a teleconsultant is legally allowed to get the information, process the information provided by an ASHA, a nurse, another registered medical practitioner, or even a caregiver. Again, this is very simple. It is not, and the guidelines emphasize this again and again. Please do not be paranoid about getting all this. Don't do things just to protect yourself. I wish to emphasize again and again that you need to do anything and everything in the interest of the patient. The interest of the patient is primary, secondary, tertiary, and quaternary. Everything else becomes absolutely irrelevant. Now, what are the types of consultation? It can be a first consult. Doctors until recently said, we will not do a teleconsultation for a patient whom you have not seen physically before. The law now allows you to do it. Follow-up is defined as any consultation or second or third or fourth consultation repeated within a period of 6 months. If you have not seen a patient physically for a period of 6 months, the law says you need to do a physical re-examination of the patient. This is absolutely correct from a medical point of view. Again, when we talk about managing a patient, when a patient comes to me face to face, the prescription part of it is secondary. All of us, particularly the older doctors, we spend time listening to the patient, advising the patient. In other words, health education, counseling, not only of the patient, but that of the family is as important or more important than medication. So all this is allowed. So the types of teleconsultation I have already mentioned. Today, the law allows you to give an emergency teleconsult. Again, ladies and gentlemen, you've got to use your common sense. Most of us may not be in a position to actually carry out the advice which we give. Therefore, an emergency should be interpreted as an emergency. It is actually a sophisticated form of teletriage. You tell the patient this chest pain could be a myocardial infarction. You always err on the side of caution and tell him you must go to the nearest hospital, get an ECG done, or actually even better, don't go to a place where only an ECG can be done. Go to a place where thrombolysis can be initiated. This is what is expected out of you. When you see a chest pain, don't say get an ECG done. No, what is the point in having an ECG and wasting valuable time unless you follow it up with thrombolysis? So I would rather refer a patient to a thrombolytic center 2 hours away. That's more judgment rather than getting an ECG done immediately. So at the end of the day, it's all about clinical judgment, Now, there are certain norms to be followed when you do a teleconsultation. I have no idea who the patient is. Therefore, it may be extremely rare, but it's not impossible. You must satisfy yourself that the person whom you are talking to, whom you are virtually doing an examination, is actually the patient being referred or for whom the consultation is sought, and not a relative and not a healthcare giver. Similarly, the patient at the other end has a right to know whether you are the actual doctor, whether you have the credentials. When a patient physically comes to a doctor's consulting room, it's unlikely that there will be an impersonation. But it's so easy to impersonate a doctor when you're other end of a camera. Thirdly, and most important, the doctor should maintain patient records of teleconsultation. This is my plea, that don't wait till the very end. Don't wait till the government forces you. It is high time every one of us, it's not as difficult as you think it is. It's high time every one of us starts adopting EHR, or at least an EMR, an electronic medical record. Today, there are dozens of vendors. All this can easily be made available in a smartphone, in a tablet, in a laptop, in a desktop. It can be stored in the cloud, extremely user-friendly. And that way, storage of data, documentation of data becomes extremely simple. You may think I made a typographical error in the last line of this slide. Clinical judgment has been repeated 3 times. Ladies and gentlemen, it is not a typographical error. The more you use technology, the more is a necessity for clinical judgment. Now, again, for example, a rectal examination. As an old-fashioned doctor, I may insist on a rectal examination. But a young doctor, he may be quite satisfied with a 4D ultrasound, and he may say, this ultrasound gives me the information I want. I don't need to do a rectal examination. That's fine. So, but on the other hand, if you want a rectal examination to be done at this point of time, at least, you have to convert the teleconsultation into a physical visit. So, in other words, you use your clinical judgment. Compliance, adherence, documentation. These are more important. The law permits you to charge appropriate fees for a teleconsultation. Whatever fees you charge in a face-to-face consultation, you can also charge. Of course, the guidelines don't mention about how the fees is to be collected. Today, there are so many methods, but a receipt can also be given digitally. So these are things which are very clear. The caregiver is deemed to be authorized on behalf of the minor or incapacitated patients. Now, here again, it is necessary that the identity of the caregiver and authorization should be checked. I'm again and again repeating, you need to use your judgment. If you suspect something, you have some reason to believe that this guy may not really be the caregiver, you have full authority to ask for an Aadhaar card, to ask for a photo card, and identify yourself. A doctor has the right to refuse a teleconsultation, A, before it commences, B, halfway through the consultation. In fact, I would consider it as malpractice if you continue with the teleconsultation, even though the bandwidth is dropped, even though the audio video is not there. You have every right to abort the teleconsultation on technical reasons, on clinical reasons. Whether you charge fees or not for this, of course, is an individual decision, what have you. Now, it is mandatory for doctors to prepare, maintain, and preserve the patient's records, meaning the history, the investigation reports, images, etc. To start with, what most of us have been doing in the earlier days for a long time, just as when I see a patient face-to-face, in my OP records, I write down very briefly the history, the findings, and I must put down my working diagnosis and a clinical diagnosis. This is very, very important. It is most unfortunate that in 2018, the Mumbai High Court, the Honorable High Court, made an observation that a doctor prescribed drugs on a telephone without reviewing the patient's clinical status. He said that this was absolutely wrong, so which statement is true, and this was quoted out of context, and for a number of years, number of months, teleconsultations fell down. I repeat, it is wrong to give prescribed medicines on the telephone unless you have made a working clinical diagnosis. For example, I may even say NYD headache. That's fine. That means not yet diagnosed headache, which means I take the responsibility. When I say NYD headache, it means, in my opinion, clinical opinion, the headache is unlikely to be due to a brain hemorrhage, unlikely to be due to a brain tumor, unlikely to be due to meningitis, and so on and so forth. Acute abdomen. Now, acute abdomen itself is a diagnosis. It means that it's incomplete. You don't know the cause of the acute abdomen. Now, if you prescribe antispasmodics and analgesics which will mask the pain in a person with acute abdomen, obviously that is totally wrong. On the other hand, if you have done a video consultation and through reasonable virtual means, you are reasonably satisfied that though historically it sounded to be an acute abdomen, when the hand was placed on the abdomen, you do not think it's an acute abdomen, you certainly can prescribe whatever medical therapy is indicated. So do not prescribe any medicine. And the worst thing which can happen is, just because somebody has been your patient, I have made this mistake so many times, now not only through teleconsultation, but even through clinical practice. 10, 20, 30 years ago, I made this mistake. Nothing prevents a person who had tension headache, who had a so-called psychosomatic headache, whom you have been putting on antidepressants and tranquilizers for the last 1 year. Nothing prevents that person from developing a brain tumor headache. So please do not repeat the prescription just because you have been treating somebody as migraine. A migrainous patient can also develop an aneurysmal bleed. You need to examine the fundus with an ophthalmoscope. At present, you do not have methods to examine the fundus of a patient. Therefore, you must say, I cannot do a teleconsultation. Something, I am suspicious. I'm not very certain that you continue to be depressed and you may be having something. So please go and see the nearest doctor or come to me physically. So again and again, I'm emphasizing that teleconsultation, you can do anything provided it is in the interests of the patient. Now, prescriptions. There is still some difference of opinion here. Encrypted digital signature. For all practical purposes, I don't want to go into the details of what is an encrypted digital signature, class 1, class 2, class 3, whether you must get it from this company, that company, etc. We'll come to that later. Right now, the practice guidelines state that you sign a prescription physically as you normally do, take a photograph of it and the JPEG image of that, or you can scan the photograph and electronically send a physical prescription to the patient, who can download that prescription in his phone. And today, the latest rules, the pharmacist has to accept a prescription digitally displayed on a smartphone, a tablet, or whatever it is, etc. A printout of a digitally displayed prescription is also valid and acceptable. Here again, there are several limitations. The law, very rightly so, prevents you from prescribing certain drugs which are too dangerous, which are habit forming, which are under various schedules, etc. However, in view of the pandemic, the list is a little more flexible than it used to be earlier. I don't have time to go into all the details. I advise you to please read everything. You will be able to understand what you want. List O, which is over the counter. List A, this scope is restricted to video consults. I've already told you that you cannot prescribe a drug on the telephone without having seen the patient or seen the patient again. Just because you saw the patient 6 months ago or 4 months ago does not allow you to refill the prescription. What about chronic diseases, diabetes, hypertension, asthma, and there are dozens and dozens of diseases where you have to be rheumatoid arthritis and so on and so forth. Clinical judgment. I expect the doctor to know that certain drugs cause renal function dysfunction, liver function dysfunction. You're a young lady, she could be pregnant, drug interaction. We expect a doctor to be absolutely professional about it, and you decide whether in that particular case it is safe to give a prescription without looking at the liver function test, renal function test, and so on. So this presentation will also be available. So those of you, please go through this. I don't have time to go through each one of this. This is the sample suggested by the Medical Council of India. But again, they've been extremely liberal. It is not mandatory. It is only a suggestion. But again, common sense tells you that when the government says it is a suggestion, it's a very polite, diplomatic say, you jolly well follow what I'm telling you as a suggestion. So please follow these instructions, write the diagnosis. It is criminal, in my opinion, to give a diagnosis, to give a prescription without a working diagnosis. It may be an incomplete, it may be the wrong diagnosis, but nevertheless, you have to give a diagnosis before you give the prescription. And please give the prescription in great detail. Now, Exclusion. So far, I've very quickly covered. It will take hours to go through this 51-page guideline in detail, but I think you have a reasonable idea of what the guidelines is all about. Another thing which is equally important, the guideline does not, at this stage, this is 1.0 of the guideline, it does not specify anything, does not talk anything about hardware, software, infrastructure building, maintenance. Of course, it does mention that the platform provider is responsible to know about the authenticity, whether the RMP, the registered medical practitioner, is a genuinely registered with the medical council. Again, unlike the laws in Europe, unlike the laws in many other countries in the world, the Indian guidelines unambiguously state that if there is a violation of patient privacy due to a technical defect, the doctor cannot be taken to task. It is a platform provider who is completely responsible. Let's say a virus comes, the antivirus software has not been updated, my records are lost, something like that. The platform operator takes the responsibility. Of course, maybe the doctor cannot wash his hands off, but nevertheless, the platform operator plays a major role. The law very clearly says that digital technology cannot be used for any surgical or invasive procedure remotely, which means I cannot do a teleendoscopy. Now, again, the guidelines are not clear on whether consultation can be provided outside the jurisdiction of India. Now, the Pan-African Network project was initiated by the Ministry of External Affairs, Government of India, where we used to give teleconsultations to 42 countries in Africa. Of course, the project at the moment does not exist, but whether that is legal or not, only we need to clarify. Patients' interests have also been protected. As doctors, it behoves us to follow the law. As in any democracy, we will of course draw attention of the authorities to some ambiguities, lacunae, and requirement for amendments. We also need to be future ready. At present, the telemedicine guidelines insist that the final prescription or counseling has to be directly delivered by a registered medical practitioner, even if AI is used.